I have the pleasure to give this on behalf of Professor Gu Wei from Beijing, who was the principal investigator of the AcoArt 1 study, basically the study which led to the approval of the first drug-coated balloon in China under the regulation of the Chinese FDA. It's actually a balloon which uses paclitaxel with a dose density of 3.5 microgram dose density on the surface, so comparable probably to the impact device. And it was actually studied initially in 200 patients at 10 Chinese sites, randomized 1-to-1, and with remarkable good clinical outcomes at 1 and 2 years, which have been published in the Journal of the American College of Cardiology. So now what is new data available from the study is that the study completed its 5-year follow-up endpoint, and we have the ability to contribute a little bit to the discussion around the potential side effects of paclitaxel devices. Just to recall the baseline characteristics of the study, it was a study dealing with relatively diseased patients. I would say in terms of the clinical characteristics of note, about 55% of the patients were diabetics, about 25% had coronary heart disease. Otherwise, and also I think a relatively high proportion of patients with Rutherford class 4 and 5, which were actually allowed in the study. Typically in most of the other DCB studies, these patients were excluded. Also in terms of lesion complexity, the study addressed more complex lesions. Upper lesion length was, if I recall correctly, 30 centimeters. So that resulted in a mean lesion length about 15 centimeters. Much longer than in other DCB randomized clinical trials, also about 55% total occlusions higher than otherwise seen in the literature. So now I think this is the most important new data point. We can see the all-cause death rates through 5 years, and we can see that actually freedom from all-cause death was 82% in the DCB arm versus 73% in the PTA arm. So if you want, not statistically, not different results, with a little trend showing here in the opposite direction than in some of the other previously published studies. Looking at the all-cause death reasons, if you want, you can see that cardiac death was the most typical, most prevalent, with about 40 to 45%. Malignancy, but everything balanced without any statistical differences. That's also tested here in a statistical way. You can see here a comparison for all-cause deaths between DCB and PTA arm, and in fact for none of the variables there was any association pulling in one or the other direction here for the two treatment groups. So just to add to the discussion a little bit, as you know, 5-year data are somewhat limited, and based on these limited data, we are discussing here very seriously the alarming signals that of a potential excess mortality in the DCB arm. You know, these are only 3 studies which have these 5-year data published and entered the Katsanos analysis. So looking at how would the picture look like if these new data would also be put into this analysis, we can actually see that, with this one additional study, the whole picture can be changed a little bit. So it pulls here actually the odds a little across the line, basically eliminating the signal in the random model. In the fixed model, which is probably the less appropriate model for looking at this interaction, there is still a borderline significance. Well, of note, also in terms of efficacy, the balloon did well. You can see here freedom from target lesion revascularization was still 77% at 5 years compared to 59% in the DCB arm. And the patients also maintained their Rutherford improvement. So now looking a little deeper on the deaths again for the overall cohort, what can we see in the AcoArt study? We can see that in terms of baseline characteristics, age and the prevalence of coronary heart disease have a significantly higher prevalence in the patients who died compared to the survivors. And if you look at the procedural variables, we can see that more, in the group of patients who died, more patients had a bailout stenting compared to the surviving group, and the lesion length was longer compared to the lesion length in the surviving group. So, if you want, this is a clear signal that there was probably, this higher lesion complexity was generally associated with a somewhat higher death rate, which is probably not surprising, but I think it's unique to show that because the study also had a lot of complex patients included. Looking more specifically at this comparison only for the DCB treated patients, you can still see the patients who died were older. They had more coronary heart disease with 47%. But of course, because of the smaller numbers, the significance doesn't come out as strongly as for the whole cohort. They had also more bailout stents, 47 versus 13%, and they had a longer lesion length, 16 versus 14 centimeters. So this seems to also be the association in the DCB group. Looking at the multivariate analysis, we can clearly see that, again, the prevalence of coronary heart disease is a strong independent predictor of death after treatment with DCB, and the provisional stenting, which probably reflects the lesion complexity. So in summary, there are no significant statistical difference or mortality between DCB and PTA over a 5-year follow-up period demonstrated in the AcoTech DCB study. Significantly lower rate of clinically driven target lesion revascularization were noted at 5 years. And of course, that's only one data point. Clearly more studies are needed. Thank you.